think we're going to get started again. We've really got three outstanding speakers that I think set the tone for the workshop this afternoon, and you never know about these things, but I don't think we're going to see a lot of overlap. I think that our next speaker is going to cover some diseases that really weren't covered this morning, and tie in particularly, not only the Southeast, but particularly for Florida. And she's actually a graduate of this university, and so has some deep connections. Dr. Andrea Morrison is a Vector-Borne disease surveillance coordinator at the Florida Department for Health. She has served as the primary epidemiologist involved with arbovirus surveillance and response in Florida for the past 8 years. In that role, she was heavily involved in responding to outbreaks of exotic arboviruses such as Zika and dengue, and yes, apparently they are here in Florida. Dr. Morrison graduated with her PhD in public health from the University of South Florida, where research focused on the ecology of eastern equine encephalitis virus in southeastern United States. Dr. Morrison?
Thank you guys so much for having me. It's nice to talk about, kind of like nerd out about the things that we enjoy, right? But also kind of get a different perspective from the occupational health side of things, and I'm definitely looking forward to that discussion at the end of the day. Okay. As Wayne mentioned, I am the Vector-Borne disease surveillance coordinator. That's really just the fancy way of saying that I'm in charge of the surveillance for these diseases in the state of Florida. I'm the lead epidemiologist, considered to be the subject matter expert, particularly for the mosquito-borne diseases, which is what I'm going to be focusing on today. And so part of those duties are compiling the surveillance information from our different sources that we have, whether it be human, animal, things like that, some of our sentinel activity as well. Reviewing the arboviral disease case investigations that our county health department epidemiologists do, and serving as a source for if they have any questions or need any consultations or things like that, developing trainings for the epidemiologists, mosquito control personnel, and developing tools and resources for others such as healthcare providers, the public, things like that. So why do we even care about these diseases? Marie did a very good job kind of opening up this topic. Our goal is to really prevent those large disease outbreaks, and we have to do that by targeting our control activities to the appropriate place, time, and population. So we need to know what agents are in an area, how they're being transmitted, when, where, the who, what, where, when, and why. And in order to have appropriate control, that could be things like vector management, trying to reduce the mosquito population. Could be things like increasing awareness in the medical community and the public. We're involved with a lot of those activities as well. And even just that personal, protective education. What can you do to decrease your risk of getting even bitten by a mosquito to begin with? So that would be things like Marie mentioned, draining standing water once a week in any containers or things like that might be holding water. Using insect repellent, wearing long pants, windows and doors, things like that with screens. Just some examples. So you may not know, but there are actually over 130 arboviruses, so viruses that are transmitted by arthropods, really in this case, mosquitoes, that can cause human disease in people. So these are gonna have almost a completely worldwide distribution. There's of course way more than that that can cause diseases in animals or even insect-specific viruses, things like that, but over 130 that can cause disease in people. And this is really just a subset of some of the ones that we are most interested in Florida. So you can see in blue here are the ones that are endemic or normally found in Florida. So that would be things like West Nile virus, St. Louis encephalitis virus, Eastern equine encephalitis virus, Everglades virus, and then I have Highlands J virus on here, which doesn't actually cause clinical illness in people, but it can be a really good indicator that the environmental conditions are really good for arbovirus transmission. And those are largely going to be in our flavivirus and alphavirus families. Now you'll also notice there are some here with little asterisks. Those are the ones that are not normally found in Florida. They're not endemic. That would be things like dengue, Zika, chikungunya, yellow fever, things like that. We do have the right species of mosquitoes here in Florida, though, so that we can have local transmission under the right circumstances. So you would essentially have to have someone who travels abroad, they gets exposed to one of these viruses, comes back, gets bitten by a mosquito locally, the right species of mosquito, and then live long enough to infect another person after that. So we definitely have the right environment here for some of these disease transmission. And then I also have on here the Bunya viruses. That's another family of viruses that we don't necessarily have in Florida, but other parts of the United States do. So I just put it on there for fun. And then malaria is on here too. It's a parasite, not a virus, but also not normally found in Florida. But again, we have the right species of mosquitoes where we could have local transmission. So how are these transmitted? I think it's important to point out the different types of transmission cycles that we're dealing with here. So this first one is where the virus is going back and forth between people and mosquitoes. So people are serving as the source of the virus for the mosquitoes. That would be things like dengue, Zika, chikungunya. This middle one here is our enzootic cycle. So this is when you have the virus being transmitted back and forth between a wild animal and mosquitoes, and then maybe those mosquitoes are feeling like, I want to feed on something else, and infect a human that way. In this case, humans are not the source of the virus, it's those wild animals. And humans tend to be dead-end hosts where they cannot infect a mosquito after that. So this would be things like West Nile virus, St. Louis encephalitis virus, and Eastern equine encephalitis virus, where for those ones, birds are actually the source of the virus for the mosquitoes. And then this third one is kind of our epizootic. It's very similar, but it tends to be more domestic animals are serving as the source of the virus. And we really in Florida are dealing more with those first two types of transmission. Again, our endemic ones fall under here, and then the exotic ones that we don't normally have, but keep having to deal with, are that more urban transmission cycle. So in Florida, I probably should have had you guys guess how many species of mosquitoes there were, but we have over 80 different species of mosquitoes in Florida. That's compared to if we looked at the entire United States, it's about 200 species or so. So there's a lot of different ones out there. I mean, if you looked, throughout the world, it's probably thousands. But most of the species that there are not actually involved with disease transmission. Nationwide, it's generally about 12 different species of mosquitoes that are involved. So a lot of these are going to be our nuisance mosquitoes, the ones that just bite you and are annoying and you want to go away, but aren't actually getting you sick with anything. But you're not going to know when you're getting bit which one it actually is. So those nuisance mosquitoes can really become a problem after heavy rains or natural disasters. Think things like hurricanes or floods. And this picture right here is actually a mosquito trap from just one night collected after a hurricane of how many mosquitoes were captured. So they can be thousands of mosquitoes in those traps. There's even been case reports, especially after some hurricanes, before there was a lot more widespread mosquito control, where animals have been suffocated from there being so many mosquitoes flying around. It's interesting. I mentioned that, again, that there's only about 12 that are disease vectors, but really depending on whatever species that you're looking at, they're going to have different habitats or breeding sites that they prefer. You might have some species that like those swampy areas. You might have some that like grasslands or salt marshes and forests. There's really the gambit here. And Aedes aegypti, which is the main species involved with transmission of dengue, chikungunya, and Zika, that one really likes to be around people, so around your homes, around your businesses, things like that. They also really like to feed on people, which is not helpful in those cases. So they're going to be in different places, but they're also going to have different feeding preferences. So you might have some, like Aedes aegypti, that likes to feed on people. You might have some that like to feed on birds. That's great for that endemic transmission cycle, the enzootic one with West Nile, for example. Then you also have some that like to prefer to feed on reptiles and amphibians. Did anyone know that an alligator can be fed on by a mosquito? They really like to feed around the eyes. Weird, right? There's some really good pictures online. I suggest you look it up. But yeah, so some of them have, again, those more broader feeding preferences. Then there's going to be active at different times of the day. Has everybody heard mosquitoes are more active at dawn and dusk? Some yes, some no. Aedes aegypti, again, that's a day biter. So there technically could be risk of being bitten by mosquitoes all day long. All right, I did throw some pictures from NIOSH and OSHA on here. So who's going to be at risk, right? It's going to be the workers that are working where mosquitoes are biting, right? That's kind of self-explanatory right there. But that's gonna, what you are at risk of getting is of course gonna vary depending on where you are, the time of day, the time of season, the type of habitat that you're working in. And Marie did a very good job of kind of outlining those outdoor workers are of course the first thing that comes to mind. But there are other people who are at risk too, right? So we have here, maybe someone's traveling for business. I'll talk about that a little bit more later on. Laboratory workers, the people who may be, coming in contact with samples from an infected individual, or maybe they're working with the vectors themselves, so they could potentially still be at risk. And then, of course, the people taking care of these, you could have maybe a sharps injury or a cut in the skin or something like that that could also put the person at risk. So talking a little bit more about Florida, we actually have a population of over 21 million people. And a large number of those individuals are people who actually were not born in the United States. And this is especially evident in Miami-Dade County, where it's over 50% of people are not born in the US. And for a lot of our travel-related exotic arboviral diseases, again, dengue, chikungunya, Zika, they're actually, we captured the reason why they traveled. And for over 75%, it's to go home and visit their friends and relatives. And they're taking the same precautions while they're traveling as they do at home, which you can probably guess is not doing any mosquito bite precautions. But it's definitely an important piece are these people who are visiting friends and relatives, especially in areas of the Caribbean. Cuba's like #1 right now, Central South America, things like that. We also have a lot of international visitors too that are coming to Florida. And then a lot of people are like, oh, the cruise ships, there's so many people coming through Florida with cruise ships. We actually don't see that many cases associated with people who traveled for cruises. Of course, we're slightly biased because I pay attention to Florida residents or people who are diagnosed in Florida, so I don't know what happens to the people who go back home and maybe get tested there. And to give you an idea of what the burden of these look like, the endemic, again, West Nile, St. Louis encephalitis virus, Eastern equine encephalitis virus are shown here in gray. The exotic, chikungunya, Zika, dengue, are shown in orange. I spend way more of my time on the exotic arboviruses than I do on the ones that we normally have here. And so this would include ones that are travel-related or potentially locally acquired. But the numbers that we're dealing with are just increasing over time. And this is based off of the 5-year grant cycles we have with CDC, which is why it's not completely up to date. But if I were to show you the next year, which I'll do at the end of 2023, we're probably about here with our exotic arboviruses and probably like here-ish with our endemic. There's just an overwhelming amount of transmission that's occurring in some of these areas. And this large spike between 2009 and 2013 into 2014, 2018 was largely driven by introductions of new arboviruses or new to the area arboviruses in the Americas, so things like chikungunya and Zika. But, okay, I keep telling you endemic, exotic, it was not always a difference. So this is just a snapshot in time. So all of these ones that I'm like, we don't have them here, we did at one point. This is just showing 1905, but we did used to have yellow fever, we used to have malaria, we used to have dengue. So we still have the right environmental conditions for transmission of these diseases. They largely went away back then because of the advent of mosquito control, habitat manipulation, even, the invention of air conditioning and putting screens on your doors and things like that helped to decrease the risk. But we still got the right environment. Going into a little more detail about Zika and dengue, Zika virus first came into the Americas. They first identified it around 2015 in South America, kind of spread like wildfire because you had people who had not previously been exposed. But because you can only get Zika once, it's largely, not completely disappeared, but I haven't counted a case since like 2018, guys. So it's been very, very quiet. And that's gonna be different with dengue, of course. We have had local transmission of one of these arboviruses every single year, almost, since 2009. So continuous problem for us. And when I say introduction, I don't mean cases. There's gonna be cases, of course, associated with introductions, but I consider an introduction when a person is exposed locally by a mosquito. It could spread after that, but it would still be one introduction. So a single sporadic case, I'm considering an introduction. A household cluster where there's maybe multiple people at the same household or the same business that are sick, I'm considering an introduction. An outbreak, I'm considering one introduction. So we've had local introductions almost every single year since 2009, but most of those are gonna be dengue more than anything else. These two diseases have very similar symptoms. Kind of non-specific febrile illness. Maybe you'll have rash, joint pain, muscle pain, maybe some diarrhea, nausea, vomiting. And then you could think you had flu, you could think you could have COVID right now. But some of the differences between the two viruses is with dengue, there are multiple serotypes. So there are 4 different ones aptly named dengue 1, 2, 3, and 4. And if you get exposed to one of those serotypes, you're immune to that serotype. But you could still be exposed to the other serotypes and still get sick. And if you've had dengue more than once, it does put you at increased risk for having more severe outcomes, known as severe dengue, things like dengue hemorrhagic fever and dengue shock syndrome. So you don't want to be getting that multiple times. It's not a guarantee, but it does increase your risk. With Zika, there is a high rate of people who get infected and don't have symptoms at all. It's about 1 in 5. That's compared to dengue, where it's about 50-50. You don't have to have symptoms to transmit the disease, though. So those people that you don't know about could still be walking around and giving it to mosquitoes. With Zika, you also have the risk of sexual transmission and the linkage of birth defects, things like microcephaly, if a pregnant woman is exposed during their pregnancy. Then there's also some autoimmune conditions like Guillain-Barré syndrome, too, that have been linked with Zika. Again, because you guys are coming from a lot of states, I kind of wanted to show nationwide and then look at Florida, but this is from CDC's website. It's the potential range of Aedes aegypti and Aedes albopictus in the United States. So, these mosquitoes love people. They like to be around people, especially Aedes aegypti, and they like to breed in containers, and they really don't need a large amount of water to breed. Think like a bottle cap size amount of water. That's really hard to get rid of all the water, right? That's that amount. The Aedes aegypti is going to be a little bit different. It's also known as the tree hole mosquito, so it not necessarily going to always be as around people as Aedes aegypti. And these species don't really fly far either. So when we're responding to these types of diseases with mosquito control, they have to kind of know exactly where they need to go, and there's a lot of hidden kind of breeding sites when you're looking for a bottle cap size amount of water. So these maps were actually just generated based off of data that had been collected from surveys of looking for mosquitoes and then using a model to try to estimate what those ranges would be. So it's not a guarantee that you would have these vectors in all of these locations necessarily, or that you would have disease in all of these locations, just that the general habitats there. But you can see for both, Florida is very likely, and that is accurate, because we do have both. So looking a little bit closer to home, distributions are maybe a little bit more nuanced than those other graphs that I just showed you, but again, this is still gonna be a generalization. So these distributions also change over time, Aedes albopictus was actually thought to have been introduced into the U.S. from Asia through used tire imports in the 80s. So this one has not always been there. When it first came, it kind of outcompeted Aedes aegypti for a bit, but it's starting to bounce back. So this is from surveys done in the 90s and early 2000s, where you see North Florida is primarily Aedes albopictus, and South Florida was a mixture of both. After Zika, they got a lot more money and redid these surveys. And you can see that the range of Aedes aegypti and albopictus, where you have both, is going northward. And even this is not completely accurate to what we have today, because the Panhandle even has some pockets of Aedes aegypti that they identified and are actively trying to get rid of. So keep this map in mind as we go to the next slide, because the next slide is going to show you the counties where we have had local transmission of these exotic arboviruses since 2009. And hopefully you guys can see it, but I want to point out mainly South Florida is what's involved. And this Miami, Broward, and Palm Beach have had everything, but no one has had the amount of transmission that Miami-Dade County has. And you just added Volusia County this past year, so the risk is still occurring even in northern Florida, even though most of the stuff we've identified has been in central or south Florida. So you can see in the orange kind of checkered, the chikungunya ones, which we only had 12 locally acquired cases in 2014. You see dengue in yellow here. That's the one that's never going away because it is endemic to areas of the Caribbean, Central and South America, and because you have those 4 serotypes, which allow for continued circulation in those areas. You can see the Zika with the blue outline, and then I have flavivirus here too. That basically just means that a person tested positive for antibodies against both dengue and Zika, and we couldn't differentiate which one they had, unfortunately. But again, you can see that was Miami, so Miami has everything. And I'm not talking about like, oh, maybe there were a couple people here, and Miami maybe had like 10. We're talking about like, there was 300 during Zika in Florida, with 285 of those being linked to Miami, so yeah. We kind of talked about reportable diseases a little bit, so I'm gonna go into a little bit more detail so you can see the nuances of that. When we're doing our human case investigation, the majority of times that we are finding out about a case are actually when lab results come in and we follow up on those. Providers are not good at reporting to us, so everything is really primarily coming from electronic laboratory results from those commercial laboratories, which kind of puts us behind the 8 ball, right? So it takes about, 7 to 10 days sometimes to get those commercial lab results back, when the providers are technically supposed to report within 24 hours of suspicion, which means you ordered the test, you should be calling, but you don't. These are the 4 things that I'm most interested in when it comes to these disease investigations, because my goal when I'm reviewing them is, does this case make sense? So things like symptoms. We try to collect the medical records from the hospitals or wherever the person sought care. We try to interview the people to obtain additional pieces of information. It would be really helpful if those electronic health records had the occupation, so I really hope that works. But yeah, the ID notes are the only things that ever have that good pieces of information, so you're absolutely right on that. So are the symptoms that the person reporting, do they even make sense? There are, for example, some tick-borne diseases where they'll be like, oh, I've been sick for years, and I'm like, that's not related to the positive test result that you had. Did the person travel? If the answer is no, I'm gonna be like, uh-oh, we've got a problem. And then the timing of travel is really important too, because we have to take the disease incubation period into account. So we are looking for travel within 2 weeks of when your symptoms started. So if the county health department is calling someone up, they're talking to them on the phone, and they say, oh, I traveled to Cuba a month ago. They did not get dengue in Cuba. They got dengue in Florida. So my next question would be, did you travel with somebody? Because if I can get a source, that would be great. Oftentimes, maybe yes, maybe no. But most of the times, we don't have a direct kind of known source of where someone could have gotten the virus, unfortunately. We also do some confirmatory testing at our state public health laboratory, and we're also looking at, do the test results make sense with the timeline of when they got ill, when they sought care and were tested? Do we need to do additional testing? Because providers also aren't great at ordering necessarily the right tests. They kind of just look on the list and they're like, yeah, well, there's this one, I'll try that one. But the type of test that they order is really, really important with the timeline of when someone is sick. And then we also notify mosquito control. So part of those interviews is trying to collect some of those risk factor information, and we do collect some occupation for the mosquito-borne diseases at least. And if the person has an occupation that could be at risk, we will also provide that work location to mosquito control for them to do their control activities. For those exotic arboviruses, remember, people are serving as the source of the virus, so we care about where you could have been exposed, so that 14 days before you were sick, and then, that 1 week or so where you could be infectious to mosquitoes after you develop symptoms. Maybe you were called mosquito bites at work or something like that after that. We care about that too. For those endemic arboviruses, we're really just focusing in on those 2 weeks before their symptoms started because they aren't serving as the source of the virus. Okay, so we do collect some occupational information, even for people who are traveling and get exposed abroad. You remember I said about 75% of cases are ones who were visiting their friends and relatives. After that is maybe some tourists, but we do see some occupations where people are traveling for business. It could just be that they are going on a business trip to an area where these diseases are prevalent. Maybe they're in the military, maybe they're an airline or ship crew, maybe they're traveling in order to do emergency relief efforts or humanitarian work, or maybe they're a missionary. Those are kind of the categories that we see most often. The percentages here are a little bit on the low side, so it's not really making up a large portion of why our travel-related cases are getting exposed, with the exception for malaria. Now again, this one's a parasite. It's going to be found in parts of Africa, Asia, and Central and South America, as well as some parts of the Caribbean. And this one, pro tip, if you do visit a malaria endemic area, you can take some pills to prevent you from getting malaria. But you have to keep taking them for a bit after you return, which is where a lot of people mess up. But a lot of these occupational risks, a good portion of them, can be among people who might be spending long periods of time in some of these locations. Think maybe military or missionaries, and they may not necessarily be consistent with taking their medication. And when you're not consistent, that opens the door for becoming exposed and subsequently becoming sick. Okay, now we're going to talk about Zika a little bit more. I mentioned that we had high numbers of travel-related cases, especially after it was introduced to the Americas. In 2016, we actually had over 1,000 travel-related cases. I was very, very busy. And then top that off, we were lucky enough to be the first state to have local transmission. I mentioned we had 300 cases, most of those in Miami. Also a great time. It ended up having 4 areas of active transmission. So what does that mean? If you have, say, an introduction where you have a couple people in a house, I'm not considering that an active area of transmission. I'm looking for clusters of cases in both space and time. If everybody gets sick at once and then nothing else happens, not an active area of transmission. But if I have someone get sick here, and then 2 weeks later here, and then 2 weeks later here, we know something is ongoing in that area. And these active areas of transmission I'll show on the next slide were publicized to the public, and there were actual travel advisories and alerts to these specific areas. So we did in-depth interviews with cases and persons under investigation for whenever anyone did call to let us know before those results came in. And trying to capture where were all the places that you went in the 2 weeks before your symptoms started. Now I want you to think, where did you go in the last 2 weeks, right? It might be I stayed at home and just went to work and that's it. It might be I went here. And how many places are you going to go while you're visiting here? So it can be a little difficult, especially with tourists and things like that. And other states did let us interview their cases as well that were exposed in Florida. so that we can get that kind of idea of where people were exposed. Because if we're having stuff everywhere, we need some help with targeting some of our education and some of our mosquito control efforts. But then, where are you also spending most of the time of your day, right? It's at work. So that's something that people often leave out, but we're gonna talk about that a little bit more in the next slide. And so we collected all of those different locations and then mapped them to try to figure out where are people getting exposed. Here's those active areas of transmission that I mentioned. First we had Wynwood, and then South Miami Beach, North Miami Beach, and then Little River. So these two areas are I don't know if anyone's ever been there before, they are very mixed use neighborhoods where you have businesses and also residential areas. These two were a little bit more residential than the other two, but they're just perfect areas, those mixed use neighborhoods, so keep that in mind of where we tend to see a lot more activity. But, I said we had 300 locally acquired cases that year. Only about half were actually in those areas. So for the remaining introductions, it was maybe a household case cluster or a couple cases at a business, but didn't progress further. So they really focused our efforts on these active areas of transmission as well. And then there was some sequencing of patient isolates that was done with some of our academic partners, and they estimated, based on the diversity of sequences that were being transmitted in Miami, that there had to have been at most 42 different introductions to get to the number of cases and the diversity that we were looking at. So there was a lot of pressure, coming in of people who traveled abroad and were exposed and brought it back. So how did we find those first cases? So I think this was like July, maybe. We had our first outbreak in Wynwood, and we initially picked it up because of these interviews and mapping that I was just talking about. At the time, we had 4 locally acquired cases identified. We had 2 in Miami residents and 2 in Broward County residents, which is the county just north of Miami-Dade County. And when we went to map the locations of where these people lived and worked, we said, uh-oh, there's 2 people that are within 150 meters of each other. And this was their work locations. And it was 1 resident from Miami and 1 resident from Broward. We would have been severely delayed with finding out that we had an active area of transmission if we didn't capture the occupational information. And so the light bulb is going off at this point, the warning symbols, right? Like, oh gosh, we need to do more here. So just north of this location is actually a residential area. So what we did after we did an investigation at the business itself, tested employees, found, oh, there's more people at these businesses that are sick. We went door to door and collected urine in all of the residences of people who let us within 150 meters of those 2 business locations. Usually the first question people asked us was, are you gonna drug test me? It's like, no, we're just collecting urine for Zika testing, it's fine. But that door-to-door survey and urine collection actually helped us to identify 6 people who were asymptomatic, so no symptoms, wouldn't have gone to the doctor, would never have gotten diagnosed with Zika, and that really hammered home that we had a problem. So I just want to point out on this slide, I don't know if you can see her very well, but that's Blake Scott, who's right over there. Blake Scott and I how long were we in Miami? Like 6 weeks? Doing some of these activities. So you have a star right here who knows everything I'm already going to talk about. Use her to your best. Okay, so I mentioned healthcare providers. We're not getting as many reports of. During Zika, we probably had a higher percentage. Electronic laboratory results are the other way we find out. So we get the illness reported to the county health department. They are going to, again, get those medical records. They are going to do those interviews and try to figure out if the person had traveled. They're going to notify mosquito control as well with the locations that they're able to get from that. So if the answer is no travel, we know we are most likely dealing with a locally acquired case unless the person is lying. But people were much more interested in talking with us during Zika than maybe some of these other diseases because of that risk to pregnant women and because it was something that was new. I think the most addresses we got from a single person was like 19. Mostly people were less than that. And in some cases, we were actually having people look at their bank statements to see the different places that they went. But anyway, we then would ask, well, do you know anyone else that has similar symptoms to you, whether it be at home or at work? Maybe you know that your neighbor was sick recently. And that would prompt us to do some additional investigation. So we might go to that business, collect samples from the people that are there, and see, if there are others that are sick. We might go door to door, especially if we have concern that it's an active area of transmission. And then the third way that we tried were pop-up clinics where we kind of just set up shop in a location. It was usually like a park rec center, and then had people come in, and if they lived or worked in the area, they could get tested. And you can probably guess which one actually worked the best, because I'm here today to talk about it. So, we ended up conducting 15 workplace investigations. And what prompted us to go to these, there were 9 cases that started some of them, where they mentioned that they had other coworkers with similar symptoms. There were some workplaces with increased risk of mosquito exposure, where they had symptomatic employees and reached out. And then we also had a concerned business that reached out and just requested the testing, though I don't think they had any cases associated with them or had any symptomatic individuals. And 8 of those 15 were in areas of active transmission. So where did we go? We went to 4 construction sites, 4 kind of semi-open warehouses where the doors are open and the mosquitoes can kind of just fly in and do as they please. There were 4 condo hotel properties. There was 1 open-air business. You can kind of guess what kind it was based off of the infographic I used here. And then 2 businesses that were completely enclosed. We would either go on site if maybe they had a bathroom or some sort of facilities where people could give us their urine, or they could come into the county health department clinic and get tested that way as well. We only required verbal consent and had a short questionnaire that collected information on their contact information, travel history, maybe any symptoms that they had. We did have to consider potential sexual exposure since this was Zika, job-related questions, and then talked about mosquito exposures at work. And for the most part, we collected urine, but in some cases, if maybe someone couldn't participate in that collection event and came later, we would collect serum if the options made more sense for the timing of when a person was ill. So if it was too far out for urine, we would collect serum and do antibody testing. And then, like I mentioned, some were tested after the collection event, but I still included them in here. So we ended up testing 423 people from these 15 businesses. We had 21 positives among 6 businesses. And you can see on this slide which businesses had the positives. So overall, the people ranged in age from 18 to 79 years, an average of 37, and 64% were male. 3 of them had no symptoms. And for those that did have symptoms, the onset dates ranged from June 30th to October 1st. And the June 30th was actually the earliest local case we ever identified. Would have been missed without doing our business investigations. So our positives were, we had 2 construction sites, 1 enclosed business, 1 open air business, and 2 semi-open warehouse type properties. And those prevalence rates for those businesses ranged from 9.4 to 17.2% among the employees that were tested. And all of, 5 out of 6 of these businesses were in active areas of transmission. The single workplace that didn't have the cases spread out in time enough for us to consider it ongoing in that location. And even some of those workplaces in the active areas were neighboring businesses, so you're seeing a little bit of clustering even within the active areas. 59% of people recalled being bitten by mosquitoes at work. 36 also recalled being bitten by mosquitoes at home, and then 69% of respondents saw mosquitoes at work. And you're not always going to remember that you're being bitten by these mosquitoes just because they're very sneaky. Marie mentioned it's very hard to assign occupational risk. If they worked in a business where we had activity, it was a lot easier. Or maybe they worked in an active area of transmission, I would lean more towards that. If they were called mosquito bites at work, I would maybe lean more towards that too. So from our 302 locally acquired cases between 2016 and 2017, I estimated that about a third were more likely to have been exposed at work than at home. And so those more, and this is including those business investigations, but also those more like one-off cases. So that would be things like construction workers, valet attendants, outdoor restaurants, retail workers, and then those warehouse kind of garage workers. So when you think about it, a lot of these would be at increased risk. They're spending a lot of time outside. When we looked at the types of properties that they were at, about half were primarily outdoors. About 32% were those enclosed kind of buildings. 16% were semi-open, and then 2% we didn't have that information. So how could a business that's enclosed? There's less risk, right? But it's not zero risk. One of those in our original Wynwood kind of business outbreak took breaks outside and ate at a picnic table during their lunch break. You could be walking from a parking garage and coming into your business. Or there was even one location that had an automatic door. Anytime people were coming in, a trail of mosquitoes were following inside of the building. And so the building had mosquitoes on the inside, even when we went to do the collections from people. So there, you gotta sometimes think of those other ways that you could have potentially have that risk. And this picture here is actually another thing that we didn't necessarily think about and kind of found out the hard way. These are construction barriers, and what are they filled with? Water. They have holes on the top that you use to put the water in. Mosquitoes can fly in that. If they have cracks in it, because maybe they're old, mosquitoes are going to come in that too. These were breeding factories in the Miami Beach area. Solution, put the caps on, guys. So not looking at just the people who work in these areas or have this potential risk. What about patrons of businesses? I didn't talk about that, right? Again, we're collecting information of where all these different people went as much as we can. So I estimated that about 55% of cases were not exposed at their own house. Think of all the places, again, that you go. And then, maybe this was at work is part of this 55%. Patrons of businesses is part of this 55%. Maybe you went to a friend's house, so it's not your own house. Still part of this 55%. And looking at those active transmission areas, again, mixed use neighborhoods, more common than anything else. We looked at, okay, where were the addresses collected within these active areas of transmission? So we collected 270 addresses among those 4 locations. Some of them had people going to the same place. So in the end, it ended up being 161 parcels. 58% of those were business related, so restaurants, hotels, retail locations. 30% were residential, and then 12% were other, think like parks, things like that. These are just some more fun breeding site pictures. These mosquitoes love tires, so this is great right there. We have some just kind of like junk outside of an apartment building, and then bromeliad plants are also a kind of a source of contention too, but they can hold water at the base of the plant. Miami Beach actually, on any city property, ended up digging up all of the bromeliad plants. But how can you solve this? Dump the standing water once a week when you can. You can't dump a bromeliad, right? So flush it out with a hose once a week, and you disrupt the mosquito life cycle. Right, switching to dengue. Again, we've had periodic outbreaks reported since 2009. We've had one in Key West in 2009, 2010, one in Martin County in 2013, and then one in Key Largo in 2020. Not going to be talking about the Key Largo one because it was during COVID, so we had lots of fun that year too. But people were at home, so I knew where they got it at that point. It made life a lot easier. Again, we've had that kind of sporadic, locally acquired cases almost annually since 2010. And 2021 was the only year where I had no local exotic introductions, and it was amazing. We've had local introductions of all of the 4 dengue serotypes too. So ignoring 2022, dengue 1 and dengue 2 were kind of our main serotypes that we see the most, but we do see all 4. 1 and 2 are what's being transmitted the most in the Caribbean, which is where we get most of our cases from. 2022 kind of flipped it on its head and was a very busy dengue 3 year, so we had the most travel-related cases we've ever reported, over 900. And then we had the most introductions, so not the most cases, but the most introductions in Miami-Dade County that we've ever had. Thankfully, did not result in larger outbreaks as far as we can tell. And I won't be talking about that either. But we did have a couple of business-related case clusters that we identified, where we had 2 people from a single business that had dengue, and then we had 2 neighboring businesses where there was 1 case in each. So you can't even just look at the same business name, guys. You gotta look at where they are. All right, so for our first outbreak in Key West, this was before my time, in 2009 and 2010. I think I just graduated like undergrad at that point, but I was doing my grad school. There were 88 cases that were identified. And what's interesting about this one, again, mixed use area, a lot of tourists, bad combination. The first identified case was actually a New York resident that traveled to the Keys and then went home, got sick, and got diagnosed in another state. So the providers also need to think of these things as well, even though this was not even on anyone's radar at the time. The virus was actually, and this is dengue 1, was able to keep transmitting over the winter, which is why we have cases in 2009 and 2010. And it was largely masked because of a flu. Busy flu year, so people were switching their gears to flu, maybe not necessarily thinking about dengue as much. Same thing happened during COVID too, unfortunately, which is why that outbreak lasted for months as well. And then you can see here that we had 5 cases from a sero survey. In contrast to Zika, if you don't have symptoms, you don't count as a case. We'll still track you, but for CDC reporting purposes, you need to have fever at least. So that's why it's 88 and then plus 5. Martin County dengue outbreak. This one had 2 different foci. We had the Rio area and then the Jensen Beach area. This one thankfully was only over a 2-month period. What's interesting is that that was their second introduction in 2 years. And at the time, they'd only ever had 1 travel-related case ever identified. So not necessarily an area that they were picking up on those travel-related cases. So just, Miami's got tons and tons and tons of people that are traveling from these areas, but other places are still gonna be at risk. Again, this was dengue 1, 28 infected individuals, 24 symptomatic. 3 of those were identified during a door-to-door serosurvey, and then 4 people who technically don't count, but were asymptomatic and identified through the serosurvey. And so similar to Zika, this was of course pre-Zika, they did some door-to-door efforts in areas where they were concerned that there was residential transmission ongoing, and then they did some business cluster investigations as well, which I'll show you on the next slide. But what first brought this outbreak to anyone's attention was the identification of 3 cases from a single business. So there we go with the workplace finding stuff again. And hopefully you can kind of see this. But these business investigations were prompted when multiple dengue cases were identified among employees at 3 businesses. So we have business A and business B in Rio, and then we had business C in Jensen Beach, and business C also had patrons of the location that were identified as being cases as well. They did things a little bit differently for this investigation. It wasn't quite like Zika everywhere, we need to do stuff. They had a little bit more time to devote to doing these in-depth investigations. In addition to actually going to the businesses where they knew they had cases, they reached out to any business within 200 meters of these locations and said, hey, we're gonna offer free testing for your employees. Unfortunately, you have to collect serum for this. You couldn't use urine like we could during Zika, so it's a little bit harder to get people to, people might be afraid of needles, things like that, and it requires having a phlebotomist go out to these sites. But there were 35 businesses that were located in that 200 meters. 11 chose to participate, including the 3 businesses where they had originally identified cases. And so they provided a serum sample, completed an interview, and these businesses were really located in small commercial centers that were surrounded by residential areas. So again, that mixed use keeps coming up for outbreaks. So those participating businesses included food service, hospitality, banking, home garden services, healthcare, religious organizations, storage services, and then marine industry as well. There were 41 people among these 11 businesses that were tested, and almost half reported using mosquito repellent at least sometimes when outdoors, not really while they were at work. Over 80% reported that their places of employment did no mosquito control efforts whatsoever, and over 60% said that they didn't maintain or landscape any of the outdoor areas, regularly at least. And 77% had at least one source of standing water on the property. And these investigations were actually done in coordination with mosquito control as well for this outbreak, and so they were doing joint investigations at the same time. So what were those items that were holding the water? Mainly buckets, barrels, and I mentioned that there were some marine industry ones on here. So uncovered boats was another source of where they were finding a lot of standing water. But in the Keys, covered boats were a problem too because water would pool on top of the cover. So you just gotta think some of these things through. Gutters, another good one. People don't think about that. Ultimately, there were 9 cases that were identified to be associated with these 3 businesses. The survey that they did only identified one additional person that they didn't already know about, and that was this new case listed here in Business B. Again, a business that they already knew was having transmission. And Business A and Business B were actually next door neighbors too, so clustering. 150 meters is not that big. But none of the other sampled businesses had any cases. So, in conclusion, I think these investigations kind of give you an in-person kind of look at the applied of maybe some of your research and things like that, of how we actually deal with things when you're in the middle of an outbreak. It does highlight the risk for mosquito exposure in the workplace, and maybe not necessarily the workplaces that you're thinking about when it comes to these exotic diseases. And those business surveys were most successful when they were performed in areas that we already kind of had an idea or an inkling that something was happening. And of course, for some types of those occupations, maybe the risk of mosquitoes was not obvious without kind of digging into those details a little bit more. And it really shows the need to collect occupation and workplace as part of that ongoing case investigations. But I think it also highlights the need to include businesses in the mosquito bite prevention outreach to begin with, developing materials that can be sent out to them, and trying to get businesses to be actively engaged in some of those prevention efforts as well. But more really needs to be done, to fully describe this day-to-day risk for these mosquito-borne diseases, but even the increased risk during, this outbreaks or times of year or years when we're super busy with imported and travel-related cases and things like that. Just how can we make people more aware of taking these mosquito bite precautions at home, but also at work and while they're traveling? I don't have a good answer for that, but yeah. And then I have my contact information.
Questions? I've got one. In 1957, my dad was one of the last domestic malaria cases in Kentucky. But back then, we lived in a house without screens. I didn't know anybody who had air conditioning for their homes. And so I'm not as daunted that this is impossible, because it seems like that we were able to eliminate malaria. I mean, you know about the history of Jamestown settlement. It almost wiped out because of malaria. And we don't have malaria in Kentucky and Virginia anymore. Had trouble thinking where Jamestown was all of a sudden. So a question I get from time to time when people talk about mosquito control is, well, okay, we can clean up the bottle caps and we can drain the swamps, but how far do we have to go? Because we also run into the Wetland Protection Act as well. How far do these mosquitoes fly?
Depends on the mosquito. So, Aedes aegypti and Aedes albopictus, not far. From many of these other ones that are involved with disease transmission, it can be miles. So it's very difficult, especially when you have the mosquitoes involved with that more endemic between birds and mosquitoes, because the birds are moving the virus too. It's a lot easier when it's people who are the ones that are kind of moving the virus more than anything else, just because they can control some of their own behaviors. Maybe if they're not feeling well, they're not spending as much time outside to even be bitten by mosquitoes, things like that. But yeah, when you have mosquito species that can fly miles, it really impacts your surveillance activities. And then, of course, there's different agencies that can control where you can spray, where you can't spray, and that really is going to have some impact too. Thankfully, the salt marsh mosquitoes are a little less likely to be involved with disease transmission, but those are the ones that are most annoying when they bite you. But yeah. I stunned you all into silence.
I don't monopolize the questions because I can ask you a bit later. But I'm grateful that you mixed in occupation a lot in your talk, and the issue that we don't always capture it, which was covered earlier this morning. But also education. Who should we be educating? Should it be county health directors? Should it be physicians? Should it be a whole mission of people? And it seems like that. There's a lot we could tell, and there's a lot of things that are slipping through the cracks, a lot of gaps here.
There definitely is. One of the biggest things is having the healthcare providers even know about these diseases so that they can test for them. But that's also a unique opportunity where they can educate and say, here's some of the things that you can do to avoid getting exposed to some of these things again, or to educate your family members. So that's kind of one piece, but really it's more of an individual risk, and those are really the harder people to get at. We had educational kind of TV monitors at the airports in Miami for people coming off of the flights from Cuba, because we were just so many, 90% of our 900 cases last year were from Cuba, and it's just, are people just blind to seeing this information? They actually, in terms of dengue, they think we already have it here when we don't normally have it. So trying to get that personal level is the hardest piece, and we have not been successful at that, so I don't have a good answer for you. But I'm hoping that more people do research in what are the things that actually make people change their behaviors, and how we can target our messages for different risk groups too.
Thank you, Andrea, for the presentation. My name is Paul. I'm an epidemiologist and registered nurse, and so having been a clinician in critical care, you mentioned the connection between Zika and Guillain-Barré syndrome. Curious, when those patients presented, did they present with symptoms of the Zika virus and then just post-development of Guillain-Barré syndrome symptoms, or what were the presenting factors in those cases that did develop Guillain-Barré syndrome?
Yeah. So we actually had 2 cases identified in Florida where we were able to conclusively say, with the help of CDC neurologists helping us to classify them, that they had Guillain-Barré syndrome. And they had the classic Zika symptoms. But from larger studies that have been done, it's not a requirement for you to have symptoms. The timeline was a little, I want to say they said within a month of when your symptoms started, you were more at risk of having the Guillain-Barré. But of course, there's other things that can cause it too. So they also had to rule out, recent vaccination, flu, other, diarrheal illnesses and things like that. I will say anecdotally that our Guillain-Barré cases tested positive by PCR further out than a lot of our other cases. We were getting, I think the furthest out we got was like 20-something days for those. I don't know whether or not that impacts the risk by having that kind of ongoing, and you also don't know if it's live virus or if it's dead virus you're detecting either, but it was just an anecdote that we thought was interesting.
It seemed to me, just like being in Kentucky and hearing about a lot of your like various exotic diseases from national news, that there was a bigger buy-in when you had the Zika outbreaks from the community. Do you think that was mainly just because of the birth defect aspect, where it's sort of a more visual impact on a group that has no way of preventing it? And if not, is there something that you could take from that experience to apply going forward, or is it just sort of a one-on-one type deal?
They played a huge role in people actually wanting to talk to us, because I don't know if anyone's been to Miami. There's sometimes people who are a little like anti-government, things like that. Chikungunya was similar though too, so I think whenever it's something you've never heard of before, people are gonna listen a little bit more. They don't care about dengue down there. We have the hardest time getting them to answer the phone and talk to us. But when we had our dengue outbreaks in the Keys, everybody wanted to talk to us. So I think a lot of it has to do with familiarity and things like that more than anything else. I will say, though, that during Zika, we also had those very, very vocal spraying and nail it and things like that, where people would do protests for aerial spraying. So we got a lot of those too, and then some people were denying that there was a congenital risk for Zika too, because they thought we were making it up and just wanted to spray them. So it's a balancing act sometimes, but for the majority of people, they were interested in us being there and helping. I feel like a lot of the people who were anti-NAILID and things like that maybe came from other areas too, and not necessarily in Florida. And then we also had a lot of people who are anti-genetically modified mosquitoes too, is kind of the big thing nowadays. So I think there's a lot of education on some of these different technologies that also needs to occur. But yeah, there's always going to be people who say no. But for the most part, if it's new and exciting and different, they care a little bit more. They actually were draining their standing water and things like that.
One last question for me, and I think we'll go to lunch unless there's any other questions. But I had no idea there's 130 arboviruses that transmitted. I couldn't even come up with a third of them. It was
that we know.
Yeah, it was pretty amazing. But y'all are pretty much the leaders here in the Southeast with arboviruses. But the world is getting warmer. Disinformation aside, which we've all had to deal with, it is. You think the rest of us are going to start facing some of these viruses here in the future, like you're seeing down here in South Florida?
It's quite possible. As you saw from those maps that are showing the two ranges of the species, there's actually been Aedes aegypti picked up in the sewers of Washington, D.C. So they have some tricks to survive those cold winters. And as things get warmer, the distribution ranges are going to keep going up. As long as you have the right population of people to spark cases is kind of the other big piece. But everything is really just a plane ride away, right? Or a ship ride away, or cargo, depending on what you're thinking about, like when West Nile was introduced in 1999. So that risk is going to increase. And then the other piece that people don't necessarily think about is that warmer temperatures actually speeds up the incubation period within the mosquito. So not only would they technically have a larger range where they could be found, but they can transmit a lot faster. I didn't talk about Eastern equine encephalitis too much, but the main vector involved with that one is Culicida melanura. And in warm temperatures like we have here in Florida, You can actually have that incubation period happen in as little as 3 days compared to 7 to 14 days. So that's another aspect that could be impacted by warming temperatures.
Thank you.
All right.
Lunch instructions, Ashley?
Lunch is in the back. Again,
It's in the back?
yes.
Okay,
And then
all right.
everyone can eat in here at their seats. And then if you would want to go downstairs, you can walk out the back doors if you want fresh air. So,
Okay, all right. Thank you.